Thank you all for coming, and thank you for the online participants who have joined through Zoom. And it's my pleasure and honor to welcome Dr. Ashish Singh on behalf of the Department of Medicine. And thank you so much, sir, for having kindly agreed to give the lecture, having come to campus and give it in person. Thank you so much. We hope that we definitely will learn a lot of things about lung cancer and its advances at the end of this session.
Yes.
Thank you. And I'll let you start the talk. Thank you.
So a very good afternoon. Thank you for having us here, and thank you for having a series of oncology topics, which you all are interested in learning. And I think you just covered a class on carcinoma of unknown primary last week. And so today my turn was to talk on lung cancer. And if you look at the recorded sessions, which is available for you, I think a couple of years ago, I was asked to talk on advanced lung cancer. And so that is available for you all to access. So therefore, I thought today, let's not go into advanced and let's focus more on non-metastatic. So that's so-called early lung cancer, right? So since the topic is recent advances, I will try to show you what has changed over a period of few years in the last few years. So what is early lung cancer? So, I mean, as you can see in the picture, anything which is confined to the organ or regional lymphatics is what is considered as early lung cancer. But in early lung cancer, it's a very heterogeneous population. In terms of incidence, if you see, about half of your patients may potentially have early lung cancer. You may not be seeing them in your medicine OPD because many times they don't have symptoms. These are picked up on incidental scans, or these are picked up in the community by physicians when they have come to them with, say, an infection or just mild cough, and they straight away go to the surgeons, right? And if you're working in an oncology hospital, from the surgeons, they are discussing the tumor board, and they don't come to you as in general medicine, at least in CMC. However, it's not uncommon for you all to kind of come across this when you are managing patients who are COPD, whom you're following up, somebody who's had a recent pneumonia. And so the moment you see a shadow on the lung, either on X-ray or a cross-sectional imaging, what is the next thing what you all do? You all would want to know what is the reason for that shadow, what's the etiology, is it malignant or is it benign? And if it's malignant, you also would want to know the spread of the disease. So if you look at staging, if you look at the Kaplan-Meier curve there, clearly you can see across the stage groups defined. And the stage groups can be, I have a pointer. The stage groups can be like, if you see 1, A1, A2, A3, 2, AB, 3, ABC. And the reason why there is so much of demarcation is because distinct difference in the terms of their survival. So much so that it's a stage 3C and a stage 4A, there may not be much difference in terms of their 3-year or a 5-year survival. And that's because of the inherent biology and the nature of this disease. So how do we approach these patients, right? Now, this is just telling you about how do we approach treatment. But before we get into treatment, it's paramount that we stage them properly or adequately, because each of these treatments have their own issues, their own challenges, their own toxicities, cost, success and failure rates. Now, so to give you an idea, in general, once you have a patient with stage 3 disease, by stage 3, you mean the disease has gone into the mediastinum, right? Most of the time, they are treated with non-surgical management. This is in the past, right? This is again changing. And why is it changing? I'll tell you when we discuss further. Disease which is confined to the lung predominantly, or maybe up to single group of lymph nodes or single lymph nodes, resection gives rise to the best outcomes, right? Now, in today's class, I'm going to tell you, as a medical oncologist, in addition to local treatment, what role do we play in order to improve their survival? When do we come in? We come in after surgery, that is adjuvant, or we need to come in before local treatment, that is neoadjuvant, right? And does it make a difference whether you come in before or you come in after? And how does it make a difference, right? So just start with the patient. She She was actually somebody who worked with us. By us, I mean in the institution. Young girl came to her physician. Actually, she went to Chittoor Hospital with cough, was found to have a shadow on the X-ray. And also the physician picked up a left supraclavicular lymph node, which you can see here on the PET scan. And the same PET scan also showed you this shadow. Biopsy from here, the supraclav node, which was done in clean minor, was reported as adenocarcinoma. And so in the last class, you would have learned whether this is what primary it is from, right? Even though here it's obvious that this looks like a primary, but you in today's day and age, nobody would take this at face value and say this is adenocarcinoma lung. They would all want to do some immunohistochemistry. The commonest is what we do is TTF1, P40, right? And P63, TTF1 and NAPSN, right? TTF. So basically for adenocarcinomas, they will be TTF1 and NAPSN positive. For squamous, they will be P40, P63 positive. And if it's just like a small cell lung cancer, that they are from the neuroendocrine lineage. So they are positive for neuroendocrine markers, which is synaptophysin and chromogram. Right? So that's a little bit of pathology you all need to know. And then you can have mixed. You can have adenosquamous and other things. So if you look at, you all know the TNM staging, right? So what, she's early stage or she's advanced stage? I've written the stage here, that the radiologists have written the stage here. T1B, N3, M0. Okay. Another thing which I want to tell you as physicians is the radiologists would write what they feel is positive, but the pathologists may not agree with that. Okay. And there is usually a discrepancy between what the radiologists think is positive. And if you happen to go in and sample each of her mediastinal node, right? Especially in an imaging modality like PET, right? What do you think is the specificity of this test of PET? It is very sensitive, right? That means if you have a positive finding, very likely, I mean, you'll unlikely that you will miss it, but just because the finding is positive, is it specific enough? About 30% of the time, it may not be metastasis, right? Right. So you have a very high negative predictive value, but the PPV is pretty ordinary for even for an imaging like PET. So keep that in mind for every investigations you see. So how did we stage her now? Now, if you look at T1 N3, who thinks this is early? Everybody's nodding. Supraclav node means it's metastatic, right? Okay, we'll come back to the patient later on. All right. So now so how do we treat this lady? How do we treat this lady? How do we treat? So do we do neoadjuvant treatment? Do we try to do surgery? If surgery, what surgery? Do we try to start her on radiation straight away? If radiation, what all will you radiate? How will you radiate? There's one mass here, one node here, right? What are the effects? What are the long-term effects of that radiation? How much of lung you're going to radiate? What dose can you safely deliver, right? If you ask the surgeons to go and operate, surgeon will be asking you, okay, they would do a thoracotomy or they would do a neck dissection or they would do a mediastinoscopy. How do we approach? And is it worth doing such a heroic surgery resection in a disease which is, of course, that node is a distant node, right? Okay, so again, so do we have evidence to guide each of these decision making, or is it just that whatever the professor says or whatever the surgeon says, right? So usually we try to be evidence based, and what I will try to do is show you the evidence of each of these strategy in the next, say, 40-45 minutes what we have, right? And when I say evidence, you'll look at it, this is, so I left general medicine in the year 2018 or so, right? Yeah, 2018 or so, right? And no, sorry, not 2018, 2008, 2010, right? And since then, so I joined oncology in say 2009, right? And now today is 2024, right? And a lot of what I was taught on how lung cancer should be managed when I was at your level, everything is changed upside down, And that's what I'm trying to show you here, right? So if you see here in 2005, 2010, a lot of these trials showed you how and when to use chemotherapy, right? In order to improve survival, right? And it's only in the last, say, 3 or 4 years, a lot of research, a lot of trials actually telling you how do we incorporate the newer treatments. And by newer treatment, you all have heard of immunotherapy, checkpoint inhibitor immunotherapy, and also a lot of targeted therapies. By targeted therapies, what do we mean by targeted therapies? If you have a driver mutation, you try and harness that, design your drug which blocks this mutant protein and therefore control the cancer, right? This again has been taught to you all multiple times. What driver mutations are common in lung cancer? So if you see, so this is just a pie for metastatic lung cancer. This is a pie for early lung cancer. And you see there's not much difference. The drivers are usually spread across equally, right? Depending on which part of the world you are living in. You can have an EGFR mutation in as high as, say, 25 to even 40%, right? I'm saying EGFR because this is very well targeted, right? It's very easily we can target this. Then actually the commonest mutation is KRAS, right? KRAS till now is thought to be undruggable because it was too complex in a protein, too complex mutations, too toxic to even inhibit it. But if you see in the last 2-3 years, there have been at least 10 to 15 KRAS inhibitors are already in research and already approved for later line treatments like adagrasib. So we'll not get into that. Now, other mutations which here on this chart, if you see, they are uncommon. But then if you just imagine how common is lung cancer in the country or in the world, right? So even if you have an ALK mutation, which is present in 3%, the total number of patients who have ALK mutation is much higher than the number of Hodgkin's lymphoma or non-Hodgkin's lymphoma, which you're going to see, right? So it's a sizable number just because lung cancer is so common. Now, in early stage cancers, if you have these driver mutations, do they have better survival, better prognosis? Okay, earlier we used to think maybe but then if you say in the absence of specific treatment, they do not confer, they're not prognostic, right? They're not prognostic. So it's just harboring those mutation EGFR or ALK doesn't guarantee you better survival, right? Now, so the patient which I showed you, the neck node, we tested for EGFR and it was EGFR mutation positive. Correct? So what do I do with the information? Correct? So we'll come back to the patient next. So okay, so let's quickly finish off the staging part. Now, as I told you, up to stage 2 or even up to 3A, the disease is deemed as resectable, right? And when you say resectable, you all can imagine what the surgeon is going to do, right? A surgeon can do a lobectomy, a pneumonectomy, a sleeve segmentectomy. Is that enough? Or he needs to also chase all the lymphatics, right? Generally, we tell them to go and remove the lymphatics, both to remove involved nodes and also to remove uninvolved nodes so that we can look under a microscope and stage them appropriately and prognosticate them appropriately. So now the main challenge here is to assign which mediastinal node is involved and which mediastinal node is uninvolved. As I told you, PET scan can be falsely positive, right? So in order to access the lymph nodes, usually we take help of all our colleagues from the surgery side, from pulmonary medicine side. So you all know the stations, mediastinal lymph node stations. Not all lymph node stations are accessible through one modality, right? So like an EBUS TBNA can access nodes which are in the vicinity of the airway, but nodes which are closer to, say, esophagus, maybe an endoscopic ultrasound FNA may be more possible. There are nodes which are like anterior to the larger vessels, maybe a mediastinoscopy, which is like almost a surgery. You give general anesthesia and you go through that, maybe an appropriate staging modality, right? And then with all this information, like the patient I showed you, we all have to sit together, who all have to sit together, different specialities, and decide what is the best approach to treat this patient, right? Okay, so now let's talk about so this is the my conclusion regarding evaluation. Correct? Anybody has any doubt till here? How do you evaluate early lung cancer? Okay, so your main evaluation is you need to know the size, the location, the involved lymph node stations, and ensure that there is no distant metastasis, bone, liver, brain, right? So therefore, you need to do an MRI brain before you subject a patient to a major surgery. You need to do a bone scan, and you need to sample each node because you don't want to be doing a surgery, an incomplete surgery, right? Like for the lady I just showed you, if we had not found out that this was a positive node, doing a surgery in the chest would be futile, right? Okay, so that's where we are. Now, I will just quickly rush through the kind of surgeries. So there is evidence to say, so that for very smaller tumors, when I say very small, that is up to 2 centimeter, you can get away with a smaller surgery, right? Like a lobar versus sublobar resection, right? With equal survival across 4 different trials. And you can do the surgery as open, or nowadays, when the surgeon is trained, they can do it as VATS, video assisted thoracic surgery. So smaller incision, lesser morbidity, earlier discharge, and then there is reports to say that survival is equal. Now, many times you will find these early tumors in patients who are frail, patients who are elderly, multiple comorbidities, right? COPD, heart problem, they don't want surgery. So there is some data to say that for up to 4 centimeter tumor, if you treat them with stereotactic body radiation, which is like a very high dose of radiation delivered almost, sometimes they call it the radiosurgery, you can get equivalent survival. So you don't have to kind of do surgery for all these patients. Again, there are recommendations for that. Now, coming to the crux of the main thing, that is the stage 3 disease, right? This is where, as a physicians, we all get involved. Why do we get involved? Because we know that with local treatment alone, the outcomes are pretty poor, and it's a huge unmet need, right? All these patients, we need to find evidence-based treatment for them. Now, stage 3, again, if you see, it's so heterogeneous, right? So you can have a tumor which is just T1 but N2. On the other hand, you can have a tumor which is T4 and N1, right? So it's so heterogeneous group. You can have, and when you say N2 disease, which is subcarinal, paratracheal, you can have like a single N2 versus multiple N2. You can have a small N2 versus bulky N2, right? And all these are important because not only because in olden days, when there were randomized trials done for surgery versus chemoradiation for multistation N2, they showed that surgery did not provide any major advantage, even though resection was feasible, not desirable, because of the relapse rates are similar. But this is just a recent consensus on how the next TNM staging should look like, right? So at the moment we are following TNM 8. This is TNM 9. And if you see this N2 multi-station bulky non-invasive, there is already people are saying they are potentially resectable. Why are they saying they are potentially resectable, right? Earlier they would say they are unresectable. I'll show you the reason, right? Now I told you that till a couple of years ago, it was only chemotherapy. Like patient would have surgery and then come to us and we would give them chemotherapy. What is the evidence? The evidence comes from multiple trials. These are all individual trials and this is a meta-analysis. And you see an absolute improvement in 5-year OS of about 5 to 6%, right? There have been trials of neoadjuvant chemotherapy, similar improvement in overall survival, right? So this will just tell you in terms of absolute figure what the impact of chemotherapy is stage-wise, stage 1, stage 2, stage 3. Blue is what you see is the absolute improvement in number of lives saved. Red here is the toxicity. So again, lung surgery is a big surgery. These are older, frail patients, and giving them cisplatin, at least 300 milligram per meter square, is not easy. And if you're not careful in selecting patients, a lot of them A lot of them have mortality. Now, light blue is number of patients where the yellow is the number of patients where the disease is cured just by surgery alone, and many of them still relapse. So in a nutshell, the standard treatment for a resected or a resectable lung cancer is platinum-based chemotherapy, which should at least be 4 cycles. Cumulative dose of cisplatin about 300 per meter square, right? And this is not new. This is 10 years old information. And whether you give neoadjuvant or adjuvant, it didn't matter. Now, sometimes when you do surgery for what you think is a early stage, but you end up finding multiple lymph nodes, or you end up having a positive margin, should you do radiation therapy just to get better local control? So we used to think, yes, maybe it will help, but till this randomized trial came out in 21, where when patients are randomized to radiation versus no radiation, you look at the survival, hardly any difference, right? So now we have level 1 evidence to say no radiation in somebody who has had surgery, right? And so now the standard treatment remains perioperative or adjuvant chemotherapy and surgery alone. Okay, so in my last class on lung cancer, we discussed how immunotherapy has made a lot of difference. Now, what people thought is, okay, let's move this treatment upfront. That's what happens in oncology, right? You look at anti-HER2 therapy, you look at endocrine therapy. First, the drug has to prove itself efficacious in advanced stage. And once it's efficacious, we study them in early stage. So these are all 4 or 5 trials where people gave immunotherapy after surgery in patients with lung cancer with no driver mutation, right? Why no driver mutations? Because in driver mutations, we know in advanced cancer, when I say driver, that means EGFR and ALK mainly, immunotherapy does not improve outcomes. What we found that the disease-free survival improved, right? And this improvement was even more profound if on immunohistochemistry, your tumor was positive for PD-L1. PD-L1 is the protein, right? Which we look at. And similar findings, this is atezolizumab, and then there is a pembrolizumab. This is a pembrolizumab study, similar finding, right? But then if you actually see, these are disease-free survival, the impact on overall survival is modest. This is when you're giving immunotherapy at the end of everything, at the end of surgery, chemotherapy, and okay. And this is the overall survival. See, one of the trials is not even positive. Why did this happen? There was so much promise of this new class of drug, but when we used adjuvant, the results we got was not to our liking, how much ever you want. Now, one of the explanation for this is how do these drugs work? You all know how does immunotherapy work? How does it work? So it's there on the screen how it works. So you have a tumor, you have your immune cells, right? And your immune cells is supposed to go attack and destroy the tumor, right? And if they are successful, they should cure the tumor. But they're not successful. Why? If you look up how does the tumor cell evades immune system, this PD-1, PD-L1, these receptors on the tumor cells, it's called PD-L1. The receptor on the T cells is called PD-1. There is an interaction. So when T cells approaches tumor, the PD-L1 kind of does not allow, recognizes the PD-1 receptor on T cells, and it kind of kicks away the T cells, right? So that MHC class, the antigen presentation does not happen. Now, this discovery of this mechanism of immune evasion actually won Dr. James Allison and Dr. Honjo a Nobel Peace Prize, Nobel Medicine Prize, right? And after that, so we're trying to block this interaction so that the tumor cells, so we're enabling the T cells to go and act better way, right? Now imagine you're trying to do all these things once the tumor is already out, the surgery is, chemo is already given, and whatever interaction you're trying to block is happening somewhere in the body, maybe in some lymph node, maybe in some liver, maybe in some lung, and that could be one of the reasons why you may probably have better outcome if you give these drugs with the tumor in place, with the lymphatics intact, where tumor priming, antigen priming is easy and more effective. And this was proved in, firstly, this was proved in a trial of melanoma. So where, as you all know, in melanoma, when it goes to lymph node, the outcomes are so poor. And once you do a resection and lymphadenectomy and give immunotherapy, that is the standard treatment. A randomized trial which gave the immunotherapy before resection showed that giving the same drug before resection improved overall survival as compared to giving after resection, right? And the explanation is just what we just discussed. So people said, okay, let's do this in lung cancer, right? Let's do this checkpoint inhibitor in lung cancer. And this is the drug nivolumab when given to these patients, atezolizumab when given to these patients. These are all individual patients, and see how much their tumors are shrinking on CT scan, right? And you see much better. 10% of these patients have no tumor when you do surgery, and major pathological response in as high as 45%. Major pathological response means the entire resected specimen has less than 10% tumor, right? So of course, with this interesting information, trials were designed where when you are giving chemotherapy before surgery, you add your nivolumab or pembrolizumab, right? And what they found when they did surgery, patients who got chemo alone, only 2% had a pathological complete response. Patients who were nivo was added, it was 24%. So 1 out of 4 patient, no tumor at surgery, right? This is just how many days of chemotherapy? 3 cycles. That's 9 weeks of treatment, right? This is MPR. MPR is again less than 10% of tumor. This is close to 40%. And so those are just soft endpoints, right? What are you interested in? You're mainly interested in, are you actually delaying recurrence of disease? And if you look at these Kaplan-Meier curves at 2 years, the difference is close to 20%, 47 versus 65, right? So just by giving these drugs upfront, the results are much better, right? In a population where the outcomes with chemo and good surgery alone is pretty modest, I should say, right? Almost half of them are relapsing at 2 years' time, in spite of getting chemo and surgery. And this difference again is better if you have a high PDL1 scoring, but PDL1 is, say, prognostic, but it's not predictive of a benefit. So that's because it's not a perfect biomarker. PDL1 expression changes within tumor and also changes with time. Sometimes when you give chemotherapy, we cause necrosis, the expression may increase as well. Okay, so this is the other study, Checkmate 816. So here again, there are two kinds of study. Some of them are just preoperative alone, and some of them are perioperative. Perioperative in the sense that you continue giving these drugs even after surgery, right? Now, both these approaches have improved survival. Is one better than the other? We don't know, because you have to compare them head on. Till those kind of trials have not been done. And it doesn't make economical sense for a company to do that kind of trial, right? If somebody shows you that 9 weeks of treatment is as good as 1 week of treatment, who will use 1 year of treatment, right? So those kind of trials have not been done. But having said that, so that's just one trial. This is another one. This is again in lung cancer. See, this is perioperative. See, the previous one was only preoperative treatment. Here, this is perioperative. See, similar findings. MPR of 50%, right? This is something which was, I should say, unprecedented, right? Our chemotherapy MPR is only 13%. And this is reflecting in your progression-free as well as in overall survival. And so based on the data what I've shown you, if you have to use the drug, would you use it before surgery or after surgery? So are there any advantage of using it after surgery in adjuvant setting? You may say, okay, there's no delay in curative surgery, you're doing surgery immediately, right? But then the disadvantage is that disadvantage would be there's no guarantee that after surgery everybody will be fit to receive it, right? So there are a lot of advantages and disadvantages of each approach, but the gold standard is overall survival, correct? So if you have a better degree of OS improvement when you use preoperative, why would you use a important treatment later on, right? So similar to the two trials I discussed, there are other drugs as well, like there's something called durvalumab, toripalimab, and this is kind of become standard treatment based on, so this is one figure which actually has put each of these trials and each of their results together, correct? So if you see, if anybody had a concern that these patients may get adverse effects and they will not come for surgery, that's not true. Almost 90, 80, 87, 81%, they're all having surgeries, right? And the response rates are almost to the tune of 75%. That is, tumor is shrinking. Major pathological responses are almost in the rate of 50% or so. And the complete responses are as high as 36% to 20%, right? So this has become standard therapy. And in conclusion, for a resectable tumor, which does not have a driver mutation, chemoimmunotherapy pre-operatively or perioperatively is the standard treatment. Okay, so we stop. Any doubt in regarding this treatment? Any concerns? How do you test for all these driver mutations? On what sample? On a core biopsy. Before we make a treatment plan, everybody has a core biopsy. And in patients where sometimes it's difficult to reach or the sample is inadequate, nowadays we have the technology to look at cell-free DNA in the plasma, right? But the only thing is the sensitivity of that is say 60, 70%. So if you pick something, okay. But if you don't pick something, doesn't mean that it's not there. Okay, so that's the thing. Okay, so that was immunotherapy. Now, what do you do for patients who have driver mutations? Like the patient I showed you has EGFR mutation. So for those EGFR and ALK, we don't use immunotherapy. So can we use EGFR therapy upfront or can we use ALK therapies upfront? Do we have evidence to say that? The rationale would say that, okay, if you use this treatment upfront, with time, if you see as the tumor volume increases, the number of subpopulation increases, your drug resistant clones may be higher and your therapy may be less effective. So rather than treating them now and wait for them to relapse and then use, say, gefitinib or erlotinib or osimertinib, should we use it upfront, right? And I don't know if you can read this. Over the last, say, 10 years or so, these are all the number of clinical trials which have established ALK inhibitors in this disease. And we don't have 1, 2, or 3. We have more than 7 ALK inhibitors currently, right? EGFR, we have first generation, second generation, third generation, and about 5 or 6 EGFR. If all this thing in the green are EGFR trials. Similarly, we have BRAF, MET, RET, but because those are uncommon mutations, we do not have data in early lung cancer. But in advanced lung cancer, if you have any of these 10 to 12 mutations, we have a drug for that. And across studies, it's been shown that they are better than chemotherapy. Now, using these tyrosine kinase inhibitor for EGFR mutation positive disease early, that is after surgery, has been studied across different lot of trials, mainly done in Asian countries. See, China, Japan, China, right? That's because this mutation is common in this part of the world, right? International trials, if you see, there was a Radiant with erlotinib. And if you see, it was a positive trial for disease-free survival, 28 versus 46 months, but not overall survival. Till recently, we have seen a large trial with osimertinib. Osimertinib, you all know, is a third generation. So it's better than first and second. Better mainly because less toxic, penetrates the brain better, and also acts against something called T790M, which is a common resistant mutation to these drugs, the first or second generation drugs. Let's see what it showed. So these are all patients who have tumor which is 4 centimeter and above, right? Up to 3A. That means they all should have had upfront surgery. They all had upfront surgery. They all had either exon 19 deletion or L858R substitution, which is the commonest mutation in EGFR. They were given osimertinib for 3 years or Standard of care. Standard of care would have been chemotherapy and observation, right? What do you see here? What do we see here? This is what? This is probability of being disease free. This is time. So these are all patients who are so-called have had curative surgery. And at 1 year, what do you see? Half of them, the disease is coming back, right? At 2 years, 46%. At 3 years, 34%, right? And if you gave them osimertinib, what happens? 84% without disease on scan, right? So now, are we curing them? Are we curing them? Why? Why do you think if the disease is not coming back, we're curing them, right? So what happens here is at 3 years, we stop the drug and you see that the curves are coming down. That means maybe we are curing some, but for some, we are just delaying relapse, right? So is 3 years who decided 3 years? ATT, who decides 6 months? Who decides 9 months? Who decides 1 year? A lot of it is arbitrary, right? Right? It's because we want to be safe first when we design a trial. If I design a trial of lifelong osimertinib, and then patients die due to toxicity, my trial is likely to fail, right? So 3 years was arbitrary, but then looking at these curves, of course, after 3 years, a lot of patients are relapsing. Now, so I asked you the question: are we curing people? So for that, we want overall survival. Correct? Overall survival is death due to any cause. And looking at these curves, what do you think? Of course, this is a positive trial. I mean, I'm not here to teach you statistics, but it has a hazard ratio of 0.49, right? And another important thing you should ask is what was the crossover? So when they relapse, how many of them got osimertinib? In this trial, it was about 40%, which again is low, right? But still, this is what we have. Now, I told you osimertinib has CNS penetration. And if you see here, a lot of the benefit is because it has prevented recurrence in the CNS, right? And here, if you see at 3 years, once the osimertinib is stopped, the CNS recurrences have propped up here, have come up here, right? Right? But if you were not on osimertinib, the CNS recurrences they start at 1 year time itself, right? So this is just to emphasize that even in early resected lung cancer, the risk of CNS relapses is pretty high. Now, when you give a drug adjuvant, that means somebody without any disease, many times you're wondering, are you treating unnecessarily, right? Is this patient really at high risk? Can I have a biomarker by which I know who needs this drug? So is there a way to, because when you do a scan, you won't see anything, right? So one such biomarker, which is being studied and which is very soon will probably be standard, is something called molecular residual disease or a liquid biopsy, looking at cell-free DNA. So in this trial, which I just showed you, the investigators just collected bloods every, say, 3 months or 6 months, and they looked for these mutation in the circulating tumor DNA. And these are all patients who are disease-free, right? And these are swimmer's plot, right? If you see the red dot, this is a positive blood report, right? And I don't know if you can see the purple square is when the disease manifested on CT scan, right? What you can see very clearly is that patients who are not on osimertinib, many of them actually had this cell-free DNA detected way earlier than when the tumor manifested on the CT scan, right? So you get a lead time to relapse, and 49% of them were MRD positive, right? Now, at the moment, this is not a perfect biomarker. We don't use it routinely, right? And just because somebody is positive, there is no evidence to say that you acting early, you are going to cure that guy, right? But then this is good to know, still research, and this is how we can probably identify a real high risk person. So these are very predictive. I mean, these are very prognostic, sorry, but not predictive at all, right? So if you have a CFDNA positive report, your prognosis is really poor, right? But treating early, it's not predictive of a better survival. right? Now, so similarly, now, if we find that if you have an EGFR mutation, knowing from all the trials I've showed you, osimertinib is good, right? It improves overall survival. So would you want to use osimertinib upfront? Again, the patient I showed you. She's got a supraclab node, mutation positive. Shall I start on osimertinib day one? Should you? Now, again, we don't do anything by gut feeling. We ask for evidence. Show me the evidence, right? So at the moment, we have the only evidence we have is a small 88 patients, right? Or maybe a small 30, 40 patients trials where you are seeing responses, but not 4% PCR, 11% MPR, not as high as just to show that it is really an effective treatment. So what I'm trying to tell you is, even if you have a driver mutation, your chemotherapy remains important, right? Because we have shown that there's improvement in overall survival. And so much so that also is because just because you have an EGFR mutation doesn't mean the tumor will behave well. Many a times they may have other concomitant mutations. Like for example, in this trial, this study, they found if you have a TP53 mutation, if you have a retinoblastoma mutation, if you have an ATM mutation, their responses are poorer. And chemotherapy possibly would work independent of what mutation you have, right? And so one should not compromise on that. Okay, so that was EGFR. We have a few more minutes left, so we'll just do ALK as well. So if you have an ALK positive disease, similar to what I showed you for osimertinib, there's a drug called alectinib. Alectinib is a second generation ALK inhibitor. We also have a third generation called lorlatinib, right? That is that has its own advantages and disadvantages. We won't get into that. But alectinib was tried again in a randomized trial, 257 patients. These are all patients who had surgery. And after surgery, they were given 2 years of alectinib or observation. They all had chemo. People who were eligible for chemo, they all had chemo. Now, what do you see here? Again, a hazard ratio of 0.24, 0.24. So, what does it tell you? 53% versus 88%. Again, this is a bad disease, because if you do not take any ALK TKI, the chances of relapse in this so-called early diseases, almost half of the patients are relapsing, right? And no, so I'm just trying to show you how control arm is performing, because as physicians, you all can make an impact even here, right? There is a huge unmet need, just because a lot of these patients, even with best of local treatment, they all fail systemically. Now, if you give alectinib again penetrates the brain, and if you see here, the relapse rates was 14 in the brain versus 4 in the brain. 14 with no alectinib and only 4 out of 130 patients, right? Right. And what about the toxicity? That is again something which you all need to know. Osimertinib toxicity, rash, diarrhea, nail changes, rarely ILD, right? And that's when it's used alone. When it's used with chemotherapy, it's even, you have toxicities from both sides, so you have to manage it properly. So as of now, do we use it with chemotherapy? We usually don't, but in advanced disease, yes, we can use it with chemotherapy. Now, similar to the EGFR, alectinib also was given just by itself in early cancers, and they found a major pathological response of almost 40%, right? So people are trying to see, okay, can we do away with chemotherapy, at least for very early small tumors, right? But we are not yet there. So in general, we finished early stage lung cancer. I showed you the data of chemo immunotherapy. I showed you the data of adjuvant osimertinib, adjuvant alectinib, right? So that's how you kind of, in a nutshell, treat resectable lung cancer with or without a driver mutation, right? Now, let's quickly come to stage 3, which is not resectable. So stage 3, which is not resectable, the standard treatment is radiation along with concurrent chemotherapy. And what do we achieve when we do that? So this was an older trial, 2010, And yellow is when radiation and chemo was given together. Blue is when radiation was given first, chemo was given next. Right? And what they found was giving it together is better. Right? But you'll probably say, suddenly you were showing me 85% 3-year survival. Now you have come to 23% 3-year survival. And I'm saying this is better. But this is how lung cancer was. And this is non-metastatic. Right? So you see how far we have come. Right? From a 3-year survival of 23 to 18%. Now, but in this population, have we made any progress? In unresectable lung cancer, which is treated with chemoradiation. So how do we, if we have to make progress here, what should we do? What should we do? Based on what I've just told you for early stage. So if you have to say design a trial or come up with an idea saying let's improve outcome, this 3-year 23% is very poor, right? Can I raise this to like say 40%, 50%? What can we do? Shall we check for mutation and add the TKI? Shall we check for PDL1 and add immunotherapy? Will it help? Let's see if it helps, right? So before this, the radiation oncologists, they tried their best to say, okay, let's go up on the radiation dose, right? So they went up from 60 gray to 74 gray. What happened? What happened? 74 gray had worse survival, right? And across, they changed the chemotherapy, they used consolidation chemotherapy, right? A lot of things was done, but did not improve survival, right? There was a trial where after radiation, whatever was left behind, they even tried doing surgery, right? And these are the results. Hardly any difference, right? Now, this is another strategy. This is a recent one, 2021. So now because immunotherapy was found to be useful in advanced disease, they said, okay, everybody who is completing chemoradiation and has not progressed, I will take those patients and I'll give them immunotherapy. And I'll see if this improves survival. So this is called maintenance, right? Maintenance in people with residual disease. And when we did this, they gave this drug called durvalumab. What did they find? What did they find? They found that this is 36 months, you have almost a doubling, right? Of number of patients who are not progressed. And this is number of people who are alive, right? So you can ask that in the previous slide, I was showing 23%. Here, my control arm is doing 43, 36%. How? Because you have taken only patients who have done well on chemoradiation. The previous slide, I was showing you all the patients. Okay, so patients who are still not progressed, patients who are still fit, only those patients went into this trial. So that's why the control arm is doing much better than what historically you would expect. And on top of it, this immunotherapy has improved outcomes. So based on this, now a standard across guidelines, once you finish your chemoradiation and you do not have an EGFR and ALK mutation, you should get immunotherapy. Okay, so in our tumor board, we keep talking to our radiation oncologist saying, don't send the patient home, send them to us because we want to discuss with them what benefits are there. Now, across trials, we have seen that, especially in some of these trials, which I just showed you, maintenance immunotherapy in stage 3, they found by doing the subgroup analysis that if you had mutations, you did not derive any benefit from immunotherapy. So therefore, trials were designed to answer, okay, can I give osimertinib after radiation? Same, maintenance, but because you have a mutation, we'll give you osimertinib, not immunotherapy. So that trial is this called LAURA, recently, 2024. Okay, so what they found was this. So anybody wants to comment on this control arm? Median PFS 7.3 months. These are all again non-metastatic patients. localized, just finishing chemoradiation, thinking that they'll do well. And on a median of 7.3 months, disease is coming back or growing again, right? And if you give them osimertinib, here it was given till progression, no 3 years and all that. The median is about 38 months, right? And in this trial has a higher rate of crossover, almost 80% rates of crossover. So therefore, it may not be possible to show an OS benefit, because as soon as you progress, you get osimertinib. Okay, with a response rate of 57%. So, and if you see here, again, there's a big difference in reduction in the progression, either in the lung or in the brain, right? So again, these are the two common sites of progression in lung cancer. So similar trials are ongoing with other TKIs, right? I mean, by other TKI, I mean with ALK, there are other TKIs. For RET, MET, other TKIs are there. So in conclusion, if you have a patient who is stage 3 unresectable, you would discuss in a multidisciplinary tumor board, right? Assess his fitness, assess his lung function, ask the radiation oncology colleague, can you encompass everything in one radiation portal? Is it safe to deliver your 60 gray to this tumor and the lymphatics? So suppose somebody is a smoker, he's got COPD, he cannot climb 2 flights of steps. If you do chemoradiation, you may worsen his pulmonary reserve, right? So that's something which you have to decide, and it's an individual decision. So there's no right or wrong treatment, and you cannot say a guideline say this, so I will give this. It's an individual decision, and outcomes are much better in experience center with multidisciplinary management. After you finish your chemoradiation, it's paramount to know whether you have an EGFR or an ALK mutation. If you have, then you give TKI. If you don't have, then you give maintenance immunotherapy. And that is the reason why we keep on insisting, get a biopsy. FNAC is not enough, right? Do not just do FNAC, adenocarcinoma, and start doing chemoradiation. Then how will you know whether to give TKI or immunotherapy later on, right? So that's the thing. So I thought I was able to kind of show you what the recent changes have been in the treatment paradigm, and we have more questions than answers, right? We are still treating a lot of patients, I should say, unnecessarily. On the other hand, we are still treating a lot of patients for much shorter duration than what actually we should be doing, right? Right? Because we know that at 2 years, 3 years also, if we stop, a lot of these tumors are coming back. Now, can a simple test like a blood test for a cell-free DNA, can that help us guide our decision? We don't know. Even when we use things like immunotherapy, what would be the actual dose? What should be the actual duration? Should I treat for 3 months? Should I treat for 6 months? Should I treat for 1 year? Again, a lot of unanswered questions for which a lot of research needs to be done. I mean, in our department, we have developed an assay for osimertinib with help with clinical pharmacology. So what we do is, because osimertinib is expensive, not many of our patients can afford it. So we actually check blood levels. And in many of our patients, we find that because the drug has a longer half-life, a lower doses is probably as good as a everyday dose, right? And that gives rise to huge cost saving. And also for the same cost, maybe I'll be able to treat the patient for a longer duration than if I use the approved dose. Okay, so now let's come back to our patient. So this is her picture while she was on treatment. So spotter, who's going for exam? Exam going batch? They're all doing thesis, so nobody's here. Okay. So what do you see? What do you see? Nails? You see a lot of this inflammation around the toe, right? So this is a class effect of EGFR inhibitors, right? So you see this rash, this acneiform rash? Okay. So we decide. So basically, you saw her scan, right? So it wasn't possible for us to do surgery. It wasn't possible for us to do chemoradiation, and she didn't want chemoradiation. She's a 23-year-old young student, and she says, "I want to go for cure. I don't want this chemoradiation and progress in 8 months' time." Right? So we said, okay, okay, let's first get the disease under control. Right? We started her on chemotherapy, cisplatin pemetrexed. We had data from advanced disease that it's safe to add osimertinib. So we added osimertinib, and this is the toxicity you see. She had diarrhea, she had fatigue, but she was able to take 4 cycles. And after 4 cycles, what do? You again regroup. You again regroup with your surgeons, with your radiation colleagues, and then you say, okay, let's do a scan again and see, right? And then we told her that there is no right or wrong. She decided to go to, she has family in Mumbai, so she decided to go to Mumbai for another opinion, right? And so decision was, should we do surgery? Should we do surgery? Now, this node, thankfully, my surgeon had done a very good biopsy and he removed everything, right? So next PET scan, there was nothing in the neck. Mediastinum also looked clean. The lung nodule had reduced, right? So she went to a surgeon. He's an experienced surgeon. The surgeon sent him to an experienced medical oncologist. After 3 or 4 multiple opinions, they decided to go and remove what we see on the scan. So they went and removed. So they found a small lesion. They entered. They removed this left upper lobe bronchus, dissected, the mediastinal lymph node dissection done, level 3, 5, 6, right? And then what we found, there was residual tumor in the lung. No nodes were involved. And then after surgery, she's continuing on osimertinib, right? So from Vellore, then she applied. She got into a course in Oxford, right? So that's her. Recently, she's graduated. Okay, and she's still very much. She's now become a patient advocate. Okay, so I'll stop here. And we can take questions either related to early or advanced or anything in lung cancer. Anything? Anything you want to discuss? Any recent patient you have seen?
Advanced cancer is if they're not fit for chemotherapy, is there a role of giving only targeted therapy?
Yeah, so that's a very good question. So of course, as a physician, you want to give the best treatment to your patient. Okay, and what is best treatment? Generally, there is this conception that chemotherapy is the best treatment. Why do you think so? Chemotherapy is the best treatment? Isn't targeted therapy the best treatment? Of course, you look at evidence, right? Now you have an old frail person who can't even walk to the bathroom, because you see only those patients, because those patients only are getting admitted, right? So you found that he has a squamous cancer of the lung, PD-L1 of 40%, right? And so now the question is, can I give a targeted therapy? Maybe not, because he doesn't have a target. Squamous cancer, smoker, but should I check? Of course you should check, because even if the incidence is 4%, 5%, for that patient it's going to be life-changing, right? So even if it's squamous cancer, where incidence of EGFR can be 5%, you must check. In adeno, it can be as high as 30%. In a female who is non-smoker, can be as high as 50%. Correct? Now, so to short answer to your question is yes, right? If you have a targeted therapy is much better than chemotherapy in terms of response rates, in terms of duration of control, in terms of survival. Now, this man who is old and who is poor performance status, would you give chemotherapy, or can you give only immunotherapy, or you should give both chemo and immunotherapy? That's the usual question which we all have. Correct? So now, someone who is not fit does not go into these trials. Correct? So where is the evidence that chemotherapy improves survival in somebody with a performance status of 3 or someone who is frail, right? Do we have trials? There are trials. So there's a trial where usually in this situation, what we would do, standard was that we'll give single agent chemotherapy. We can just give carboplatin. We can just give gemcitabine. You can just give pemetrexed, right? But then in today's day and age, if you have no mutation and if you have a PD-L1 expression, a checkpoint inhibitor immunotherapy has better survival than giving single agent chemotherapy. Okay, so it's not that there is no treatment. Someone who is really like end stage terminal, of course, those patients we would not treat. But if as long as they're up to ECOG 2, we would want to give them some treatment. Okay. No online questions? Okay, sure.
Can I ask something about treatment?
Yeah.
Obesity patients, significant smoking bacterial history. The patient profile that comes to us is usually middle or lower class. The screening guideline will say do a low dose HRCT for everybody above 50 or significant. So how do we apply it in ROPD? Who do we do the low
So your
dose?
question is screening for lung cancer. Is it helpful? Right? Now it's a controversial question, right? You know that there have been so many trials, meta-analysis, right? And the main thing is, which are the, I mean, screening in general, which patients do you want to screen for? Not only lung cancer, in general. We screen for cervical cancer, right? Why do we screen for cervical cancer? What are the 3 or 4 important things which is important for you to screen for a cancer? One is the cancer should have a long latent period. There should be a period. Do you screen for a Burkitt's lymphoma or a DLBCL? You don't. But you screen for cervical cancer, breast cancer, colon cancer, lung cancer. Why? Because cancer should have a latent period, number 1. Number 2, there should be treatment available. Number 3, the treatment should improve, should cure, right? Like why is there so much controversy on screening for breast and prostate? Because you screen, you diagnose, you treat, right? But you don't improve survival. That's because you're picking up indolent disease, which would have gone undetected during the lifespan of the patient. Now, coming back to lung cancer, the main controversy there is that survival advantage, as of now, no trials have shown. Okay. But then, of course, if you screen, you will pick up more. What are the harms of screening? It will lead to invasive diagnostic procedures, complications due to that, right? So the number needed to harm is also important as opposed to a number needed to save one life, right? So as of now, do we have a screening program in India? No, we don't have. Are there trials from India? I think National Cancer Grid was about to do a trial. I don't know what happened to that. Now, HRCT should be done. Of course, if your risk is high, if you're a smoker, COPD, of course you should do, right? And if you pick up something, hopefully you will pick it up before they are stage 3, maybe stage 1, stage 2, and you could treat them with whatever we just discussed. But if you're going to screen and pick up stage 4 disease, but that is not the benefit of screening. Okay. Thank you. Yeah.
Applause.